Good afternoon, everybody. Thank you for coming along. We're going to go straight into the presentations. I'd just like to welcome Jonathan Lucas to the stage for the first talk.
Thank you very much for having me. My talk is on preoperative spinal education POSSE intervention for spinal fusion surgery, in that it is safe and could reduce length of stay, a prospective cohort study. My declarations, no others had any declarations. So, preoperative education counselling components as part of an enhanced recovery after surgery, an ERAS programme, have been shown to improve surgical outcome, reduce complications and length of stay for many surgical specialties. To date in the UK, there is no evidence that such preoperative education counselling programmes are efficacious for spinal fusion surgery. Our aim was to develop, incorporate and evaluate a 1-hour psychoinductive preoperative spinal education programme called POSSE to assess outcomes as to whether or not it would reduce length of stay and be safe. Our principal outcomes were outcome measures for uptake of the programme, length of hospital stay, complication rates, and our secondary outcomes being whether the programme improved patient preparedness and familiarity and reduced their anxiety during the surgical process. The programme was developed through the Rehabilitation Treatment Specification System and consists of 1-hour patient face-to-face group meeting of up to 10 participants as part of our standard pre-assessment process. It was conducted by our senior spinal physiotherapist and our senior clinical nurse specialist. It consisted of a talk, a video from one of the consultants, written material, and a question and answer session at the end, with the aim of normalising the expected post-surgical pain and function, the physical rehabilitation programme that they were going to undertake, the hospital procedures, and also the discharge expectations, while minimising their overall anxiety prior to this surgery. Our methods consisted of 150 patients undergoing degenerative spinal fusion who were offered the POSSE programme in December 2018 onwards. This was compared to a retrospective series of 150 patients with similar surgery from November 2017 to 2018 prior to the implementation of our POSSE programme. We had an already existing standardised post-operative discharge criteria in place, and this gave us 3 groups of patients. The pre-POSSE group, those that attended the POSSE session, and those that DNA'd from it, although they had been offered it. And this statistical analysis was with the SPSS system, and ethics approval was obtained. Our results. There were 150 patients in the pre-POSSE groups. Of the 150 patients that were offered the POSSE programme, 43% attended, 57% DNA'd. There was no statistical difference in the age or sex of these 3 groups. In addition, there was no statistical difference in the type of surgery that they had. The majority had a single level fusion plus or minus decompression. We also included those transition adolescent idiopathic patients who made up 15 to 20%. So looking at our outcomes, the length of the median, and this is important to emphasise, the median length of stay pre-POSSE patients was 5 days, and post-POSSE it was 3 days. This was statistically significant, and I would argue a clinically significant difference. There was no significant difference between any other group comparisons, although the DNA POSSE group still showed a trend towards decrease in their length of stay. Of the 65 patients who attended POSSE programme, 85 filled in a pre- and post-programme link-art scores for preparedness, familiarisation with the process, and anxiety. Patients were statistically more prepared and familiar following the POSSE programme and statistically less anxious. Complications. There was no statistical difference between the three groups for complications, specifically readmission rates, primary and secondary in-hospital complications, and the 6-month post-discharge complications. They were all essentially the same. So in conclusion, we had an uptake of 43%. We could discuss why. And the POSSE programme achieved a statistically significant reduction in the median length of stay from 5 to 3 days, with no statistical increase in complication rates, and thus, in my opinion, can be considered to be safe. It also statistically improved the patient's feeling of preparedness and familiarity with what was going to happen to them and reduced their anxiety. As far as we are aware, this is the first programme of this type in the UK that demonstrates the efficaciousness of this type of intervention. Obviously, there are limitations, the principal one being the relatively small numbers that we had, and this is an ongoing evaluation programme. Thank you very much for your attention.
Thank you very much. Do we have any questions?
I have one. How long did it take to sort of get this program together? Obviously, you've got 2 experienced clinicians doing it.
It took about a year and a half to get it up and running. The first part was there was a collective meeting between 15 healthcare professionals, so occupational therapists, psychologists, consultants, to establish the nature of the process, and this was combined with 15 patients to see what they wanted to know. So they were used as guinea pigs, and then the program was formalized and then implemented.
And you said you have small numbers at present. When do you think you'll have enough numbers to say this is what we should be doing?
Well, delivering elective care at the moment is quite difficult, so I don't know. But I think if we can get to 300, that's a realistic. Because interestingly, the literature for the efficacy of this type of procedure is quite equivocal. We have demonstrated that with implementing this, we've reduced our length of stay quite significantly. And that may be, in fact, multifactorial, that it as reflected by the decrease in the DNA'd POSSE patients, because everybody is focused on it. It's rationalised what everybody does and what the achievements that can be made as working as a team. So the nurses, every patient or nurse knows that we're looking for a discharge on day 2, day 3, while before it was all a bit sort of vague. Mr. Selman.
You mentioned there was about a 50% take-up rate, i.e. a 50% couldn't be bothered, presumably,
yes.
rate.
Well,
why was that?
Why was that? One was geography. We serve the southeast of England, and therefore getting from the coast, Eastbourne or somewhere up, is difficult. 2, motivating people to come. And also, I think this is a very good way of motivating them. We can say this demonstrates that patients do better, and we can be more enthusiastic about delivering it, and we can improve our marketing of it.
Do they come up for a consent clinic?
Yes. So this is combined with the pre-assessment process, which means that when they're seen in clinic, they go to the pre-assessment. They then have to come up for a consent clinic at which we try and do this at the same time. They get confused that they think they have to have another visit to do this. Sometimes they do and sometimes they don't, but we try and make it such that it's a seamless progression. So it's one visit for consent and this, so we can do it at the same time.
Sorry, just one comment, Jonathan. Hi, thanks for that. It's brilliant. So do you think that's a bad thing if people choose not to go through POSSE? Because maybe it's a little bit of this shared decision. They're sharing. They're happy. They don't need anything more.
Yeah, no, I absolutely. And in fact, if you were quick enough, you could see that 9% of the patients were more anxious after the POSSE than they were before, because they think, oh, crikey, this is a real big deal. But I think your point is well made, and that's the point about these things. We're packaging them together where we're all individuals. So I think for the majority, and there is quite good evidence that if you lay down when the day at which you're expected to go home, if you say that at the beginning, they're much more likely to achieve it than if you hadn't. So by setting goals like that and dispelling some of the extreme views that a minority of these patients have, overall, for the majority, it is better. But does everybody need it? Well, the answer is no. But can we pre-pick them? No.
That's great. Thank you very much.
Thank you.
Can I welcome Daniel Chen to the stage, please?
Hi, good afternoon, everyone. My name is Daniel Chen. I'm on F1 from Queen's Medical Center. So today I'll be talking about the effect of multidisciplinary spine conference on the management plans and also outcome in adult spinal deformities. No conflict of interest. We know that the adult spinal deformity surgery does improve patient quality of life, and it comes with high complication rates of about 30 to 70%. Yet, there's no consistent manner of care delivery. There's no universally accepted guideline. Therefore, multidisciplinary spine conference aims to standardize a holistic patient care that pairs the patient with an optimal intervention. So the multidisciplinary spine conference at our center was established since 2019. Referral criteria includes any adult deformity patients requiring major spinal surgery. That's defined as fusion requiring more than 4 levels, and patients with any number of comorbidities. Participants include minimum of 2 spinal consultants, spinal fellows, intensivists, anesthetists, geriatricians, radiologists, pain specialists, and also physiotherapists. So the aim of our study is to evaluate the impact of MSC with regards to rates of in-hospital complications, 1-year complications, and also 1-year revision surgery. Complications that included in our study included any immediate complications like CSF leak, cardiovascular problem, infections, surgical failure, readmission to hospital, and also death. So methodology, we compare 2 groups of patients, pre-MSC and also post-MSC patients. So in total, we have got 59 patients discussed in our meeting. And of these discussed patients, 58% got approved for surgery, with the remaining 42% rejected for surgery. Of those approved for surgery, 3 of which underwent a pre-optimization before going for surgery. And as of now, we have only got 17 patients operated with 1-year follow-up. This low number is due to the COVID pandemic that tremendously affected our surgical load. For example, here we have got a 73-year-old female with multiple comorbidities discussed in our conference. After conference, patient required a further pulmonary function test that came back normal, and the patient proceeded with the surgery with T10 to pelvis stabilization, with T4PSO, and also multiple chevrons osteotomy. Here again, we have got another 73-year-old female with multiple comorbidities of uncontrolled type 2 diabetes, rheumatoid arthritis, stage 3 kidney disease, and however, patient has got an unrealistic expectation of hoping to get back to daily activities without any support or any walking aid. So after discussing in the conference, we think that the risks overweight the benefits, so the patient was refused of surgery and was eventually treated conservatively. So the 17 operated patients were compared with our 49 pre-MSC cohort, and statistical analysis shows that there's no difference in average age, female to male ratio, average BMI, average comorbidities, and also average number of level fusions. And the statistical analysis shows that there's significant reduction in 1-year revision rate. And we can see that there's a decreasing trend in the 1-year complication rate, although the p-value is not significant, and this is likely due to the small number in our pre-MSC cohort. So discussion, we know that the literature on this topic is scarce, and the closest one to our study was by Sethi about the effect of MSC on complex adult scoliosis surgery, but not adult deformity surgery. And findings were concordant with ours, showing a reduction in complication rate. And there's also another systemic review by Barch, and it discussed general elective spinal surgery without focus on complex spinal surgery. As of now, our MSc is still ongoing, and we have got more than 70 cases in our database. So in conclusion, the use of MSc in complex adult spinal deformity has led to a significant reduction in one-year revision rate with a decreasing trend of post-operative complications. Thank you for listening.
Does anybody have any questions?
How long do you think? Oh, sorry. How long do you think it's going to take to catch up post-COVID? Any ideas how you were struggling as everybody else?
I'm afraid I do not have any idea because I
Don't
don't work in this spinal service.
Okay,
at the
okay,
moment.
that's all right.
But thank you for the question.
I really put him on the spot then.
Thank you very much. It's been unfair, but the Hospital for Special Surgery said you're kind of late to the game here. In that there are established pathways for the pre-assessment of these complex patients for these complex surgery. And although specifically the evidence for having the MDT is not there because it's part of a pathway and it's taken as read that you would have it. So my question is, why has it taken so long to have a MDT?
You mean, why does it take so long for our MDT to be established?
Yeah, because it was only a couple of years ago. Is anybody from Nottingham here? Oh, hello. Hi, Nat.
Thanks very much. So Nasreen Qureshi, Nottingham, I'm the senior author. So as you probably know, in Nottingham, where we sort of overdo our MDTs, we have MDTs every single day. Time is set aside on our job plans from 8:15 to 9:30 every single day for an MDT. We've been doing that for almost 10 years now. What we've never had is a combined complex adult spine MDT with critical care, osteoporosis, physios, anaesthetists, and I think that's the sort of the new aspect that we started in 2018, 2019, and that, as I say, was at the back of quite a high complication rate, looking at medical as well as surgical complications. So I think the MDT is a very sort of specific MDT with the relevant stakeholders, if you like, and we've probably got, 60, 70 cases now, so the ongoing data analysis is still happening. Yeah, and sometimes, as you know, with the MDTs, once they're reviewed, they proceed with surgery, they still need a lot of tests going forwards, osteoporosis workup, so on. So sometimes, even though they're approved, we don't then even do the surgery maybe a year after that. But yeah, so we found it so helpful to sit down with our colleagues over these.
Thank you very much.
Thank you.
And next up is Anthony Gibson.
Hi there, my name's Tony Gibson, one of the West of Scotland orthopaedic trainees. So I'm just going to present our evaluation of service from our virtual spine clinic, basically where we sent out patient-reported experience measures rather than PROMs to find out what the patients actually think of our service. We've got no declarations. So this service has been around for a while. It was founded in October 2016 in response to our rising waiting list. And you can see that over the first few years of it running, it had a significant influence on the wait time to be seen. And you can also see that the number of appointments we were able to offer was increased by virtualizing parts of it. So what did we actually do? So we looked at the pathway and had assessed which parts of it we could potentially cut out and identified this new spine clinic referral, new spine clinic appointment without any imaging as a place that we could potentially save some resource and perhaps see more people with the available resources we had. So it's obviously been in place for a while, and you can see this is the split of patients that were seen virtually and face-to-face, which changed over time and certainly changed during the COVID pandemic. So what do we actually do? So our method was to send out a modified version of the generic short patient experiences questionnaire, which is a validated PREMS form, so an experience measure, as well as EQ5D and EQ-VAS forms. We sent them out to 140 patients. We had a pretty poor return rate with only 35 forms returned. And we then sent out and gathered similar forms on 35 patients seen purely face-to-face who had never gone through the virtual spine clinic pathway. So these two groups were relatively similar in age. They weren't well matched for sex, unfortunately. They were quite different in those groups. However, their overall quality of life was fairly similar, with EQ-VAS scores and EQ5D scores similar between the two groups. And we were also, because we're in Scotland, able to measure their deprivation index. So there's a Scottish index of multiple deprivation, which allows us to estimate from their postcode how deprived the patient's background is, and they were also very similar. So the patients that we looked at, by the nature of the way our pathway works, all of the virtual spine patients were referred from primary care, so either from a GP or physio, but 15 of the face-to-face patients had come through secondary care. There's a spread of diagnoses between the two groups, with slightly more back pain on the virtual spine path and slightly more radiculopathy in the group that was seen face-to-face. But what we should note before we get on to the results of the patient's experience is that prior to review, the face-to-face patients, a majority of them had had their imaging done, whereas none of the patients, by definition, because they went down that virtual spine pathway, had their further imaging done. And it should also be noted that 9 of the virtual spine patients were able to be discharged without any further imaging. So they were seen virtually and discharged virtually. So time to be seen, I guess this is what we'd been aiming for at the start, trying to improve this, and it certainly was seen. So the time to be seen in the virtual pathway was 53 days, and the graph or the bar chart on the right, what that means is that when they went to the virtual clinic initially, so they were telephoned by the virtual clinic initially, they then, majority of them obviously had to get some further imaging, and that includes the time to get that imaging and to get a decision on the right. So the mean time to an appointment where they got a decision was still twice as quick in the virtual group. So what did the patients think? So the results from this form showed in the communication domain, it was patients felt that a face-to-face appointment was superior on all 3 portions of it. In the information domain, they felt that it was superior in 2 out of the 3. And in terms of organisation domain, again, 2 out of 3 of the domains, the patients felt better treated or more satisfied through the face-to-face appointment. In terms of the patient perception of service, the perceived overall benefit from hospital care was felt to be better in the face-to-face group, but mistreatment was roughly similar between the two. So what conclusions can we draw from this? So more patients are seen quicker through our virtual process, but patients had greater satisfaction from the face-to-face appointments. And we can speculate as to why, and it's difficult to draw too much of that from our data, but it's probably something to do with being more satisfied when decisions are made at that first sitting, because the first appointment with adequate imaging was obviously much more common in the face-to-face group, and probably there is some dissatisfaction with being discharged having never physically been seen with a doctor, as was the case for 9 out of our 35 patients. And that's me done.
Thank you very much. Do we have any questions?
Hi, thank you for a great talk. Otto van Arks, RUH Bath. I'm also the Chief Clinical Information Officer and run a non-face-to-face, and it's a variable uptake. I mean, did you have to, was it purely telephone or do you use video as well?
Purely telephone, yeah.
Okay, so do you think there's a hybrid world where patients, you could increase satisfaction if you brought in a video? I mean, it's laborious, it's a lot of work, and us as clinicians don't always like to take up the video side of things, but you can share scans and that sort of thing. Do you think you could enhance the patient satisfaction that way?
I think we probably could. Yeah, I still think from that limited data that we have, there is, I do get the sense from it that people still prefer having hands placed on at some point during their pathway.
Thanks. Joshua George from Manchester. Do you see more patients in your virtual clinics than in the face-to-face clinics?
So overall, the initial patient review, if we go
I
back
mean,
to,
per clinic is your template for the
so
virtual
Twice
clinics?
as many.
It is twice.
yeah, so if we go back to this slide, that one there. So we see, these are older slides. This is data from going up to the end of 2020. But yeah, a greater portion of the patients are seen virtually from their first initial referral than are seen face-to-face.
Maybe I'm not understanding this well, but say if you're seeing 10 new patients in a face-to-face clinic, would you see in a virtual clinic more than 10, say 12 or 15?
So the patients go through a triage process when they're first referred, and then they're assigned to go into the virtual clinic if they're suitable for that. So someone who can hear, someone who's not had all their imaging done. And during those clinics, our template would be for between 8 and 10 patients. If someone's gone directly for a face-to-face appointment for clinical reasons, then it would be a similar number for that. So it would be between 8 and 10.
So it is the same number?
No, it's not.
No?
Nope. Neil Craig, Glasgow. Hi. We see 6 to 8 patients, new patients, face-to-face, and 12 to 15, depending upon who's doing the clinic, whether it's an ESP. 2 points. How come so many of the GP referrals had MRI scans, Tony?
So a lot of those would be patients that had imaging done and then gone back to the GP after and been re-referred, basically,
Okay.
and had been deemed acceptable in the initial vetting that imaging was done. So it might have been done 6 months ago and then referred back.
And the other point is, how do you think the figures would change now that it's a 400-day wait for both virtual and
Yeah, so the
and
things have changed
face-to-face?
fairly dramatically since the
COVID.
exiting the COVID pandemic.
I'm really sorry, we're going to have to move on to the next presentation now. Thank you very much, Tony. Can I welcome Ashad Noor, please?
I'm not Ashad Noor. Unfortunately, he's not been able to join us today. I'm Peter Lofferman, one of the spine surgeons in Leeds. I'm going to present some collaborative work we've done with one of our non-spinal partner hospitals, looking at the clinical utility of repeating MRI scanning in patients within 12 months in the management of lumbar disc disease. Here are our disclosures. So I think we all recognise that MRI is the gold standard investigation when treating patients with lumbar disc disease. And there's been some recent very useful guidelines for Cauda-Equina syndrome that kind of point us towards when we need to organise an urgent MRI scan. The patients we're talking about here are patients who've got long-standing degenerative problems. They've had an MRI scan and they're turning up again in other centres, in primary care or in ED, with only minor changes in their symptoms, having repeat scans. So we wanted to measure the real-world rate of change on those scans to try and help clinicians decide which patients need to have a new imaging episode. So we looked at all patients in this partner hospital over a 10-year period who had 2 lumbar MRI scans within 12 months. We looked at the main level of the vertebral pathology, the location of the disc prolapse, and then we split them up into the time interval between the 2 scans in 30-day intervals to see if there was a change over that period. We then categorised the scans into 3 groups. There was either no change, there was radiological improvement, or there was radiological deterioration. And then we noted whether or not any of these patients who had 2 scans went on to have surgery immediately after the second MRI scan. So we had 783 patient episodes in that period. 481 were included in the analysis after we excluded ones who'd had other pathologies based on their scan. So overall, 81% had no change in the scan, 15.3% showed a deterioration in the scan, and 3.7% showed some form of improvement. And that fits with what we're expecting in clinical practice. And only 3 of the patients required urgent surgery after their second scan. So if you look at the spread of the level of pathology, most of these are multi-level disc disease. When it's down to one level, it's predominantly at L5S1 or L4-5, as you would expect. The radiologist had classified the stenosis as either central, paracentral, or lateral. So effectively, central stenosis, paracentral disc, or a far lateral disc. And if you look at the percentages with radiological change or not, that's the same in each of those groups. This is where we've split it up into different 30-day intervals. And you can see the pattern's the same throughout the whole of the year, the whole of the gap between the scans. The majority of people had no change on the scan, a small number showing a deterioration and a small number showing an improvement. So these are the 3 cases that required surgery after their second scan. Our question was, are we missing, if we didn't do scans as regularly, would we miss some? So the first case is somebody who had an established new disc on the first scan, had a change in symptoms, and the disc was bigger for the second scan, so that would have been picked up by the GIRFT pathway. And the other 2 were patients who had pre-existing stenosis. They had worsening of symptoms, and their surgery was for symptom control, not because of an acute emergency situation. So there's definitely no alternative to a detailed clinical assessment in determining whether or not an MRI scan needs to be repeated. Especially in patients where we've got any suspicion of cauda equina syndrome, we've got very good guidelines on when that needs to be performed. But when we've got clinicians who are in non-spinal partner hospitals, we think we can reassure them that repeating a scan within 12 months in a patient who hasn't had a significant change in their symptoms has a low chance of altering the management plan. Over a 10-year period, we only had 3 patients where the second scan led to a change in management, 1 for cauda equina syndrome and 1 for a change in symptoms leading to a need for symptom control. We believe this is helpful data for those partner hospitals. Thank you.
We just have time for 2 questions.
Perhaps just one quick question. The very last from your data, there's a big proportion of patients who had scans within 6 months of the first scan. So it's no surprise that perhaps the vast majority had no changes in the appearance of their MR scans. But these days we see patients refer to us with more than 8 months, or sometimes even 1 year, with 1 year after having the first MR scans. Did you see any difference, for example, for those patients who had MR scans within 6 months and more than 6 months?
Yeah, we've chosen that 30-day, those 30-day increments just to show the spread, and it hadn't changed across the period. If you compared it for any other time point, it was the same, really. And so I think the decision is this somebody who's had a legitimate change in their symptoms, and should they be following that GIRFT pathway of having a new scan, or is this somebody who's just repeatedly attending because they've got a problem and they're not accessing the healthcare in the correct, in a way that's useful for them. And we see that more and more with limited resources. And I think this is just to reassure people that unless there's been a significant change in symptoms, you probably don't need to do a repeat scan.
What if it's a recurrence of similar symptoms in complete cauda equina? Because we see loads of those that come back every 6 months with another episode.
Yeah, so absolutely. And I think, the GIRFT document's is quite useful because it says that if you've had a recurrence within 2 weeks, that's when people need a scan. And I think that's what we should be kind of focusing our MRI access on, is recurrent or new symptoms within 2 weeks. That means a new scan. It's the kind of grumbling problems. It's been a bit worse. We shouldn't be scanning those people. That's kind of our take on it.
That's helpful. Thank you.
Thank you to all the speakers. Really good work.